Hello, I'm Norman Swan. Welcome to this program, The Journey Back, Rehabilitation After Stroke. Over the next 10 years, an astounding 500,000 Australians will suffer at least one stroke. 20% will die within the first month. Nearly 90% of survivors will live at home, and almost all of them will have some form of cognitive or physical disability. Many are unable to return to work, and there's social isolation and depression. Appropriate services for rehabilitation and long-term recovery are limited, particularly in rural Australia. This program is the second in a two-part series looking at the stroke patient's journey. The first, which you may have seen earlier this year, looked at acute stroke management. This program focuses on the rehabilitation and return home of people with stroke. We'll look at the most up-to-date recommendations for assessment, rehabilitation and ongoing care, and talk about some of the initiatives designed to promote better post-stroke care for people in rural and remote areas, plus their families. Now, for those of you watching on your computers, you have the facility to type your questions directly into the studio. Now, you just click on the Live Talk tab on the right-hand side there at the top of the web page you're looking at. And remember, to answer our poll questions, you click on the Poll tab at rhef.com.au. So that's also just to the side there of the Live Talk tab. And it also means that we can ask questions of you. It's a two-way street. So this is for the people watching us on the webcast. Can you tell us where you're located in metropolitan, regional, rural or remote Australia? So click the poll tab, where are you located, and I'll come back to your answers in a moment. Now let's meet our expert panel. Debbie Casper is Director of Rehabilitation at St John of God Health in Bendigo and Warrnambool in Victoria. Welcome, Debbie.
Hello.
Debbie's worked as a rehab physician specialising in stroke care and has been very active in helping people develop programs to support better stroke care throughout rural Australia. Debbie was on our last stroke panel. Melissa Gill is a speech pathologist by professional background and is stroke care coordinator for the McIntyre and Tablelands cluster in Armidale, New South Wales. Welcome, Melissa. Melissa is responsible for service development and coordination of stroke care in the region and for the provision of stroke education for a range of healthcare providers. In a previous existence, Melissa was Rural Stroke Project Officer for the whole state of New South Wales, responsible for piloting and establishing rural stroke services. Michelle Sharkey is a social worker and the Executive Officer of the Stroke Recovery Association of New South Wales. That's a community-based organisation offering support in the community for people affected by stroke and their families. Welcome, Michelle. And Warwick Hayne is a general practitioner in Wauchope, New South Wales. He's also Medical Director of the Rehabilitation Unit at Wauchope District Memorial Hospital. Welcome, Warwick. So welcome to you all. 500,000 people, David, that's a lot of people. I mean, what are the stroke rates each year?
Well, new strokes a year are 45,000, and that's an incredible lot of patients affected by stroke.
But I thought rates were going down. 2% drop per annum, that stroke was disappearing as a problem.
But we're growing older, so it's counterbalancing the stroke rates, unfortunately.
So it's a bit like cancer. Whilst the rates are going down, the numbers are going up. What's your impression from what you see going through your unit in Warwick as a GP?
Well, certainly from a GP now being focused in rehab, for me it seems like an increase in the number of strokes because I'm certainly managing a lot more. It's also, I've got a great appreciation of the recovery that people get now. That's something that as a GP you might have seen it for one or two people, but you see a broader range, and so I'm certainly seeing now the potential recovery that people can have.
Does rehabilitation, Melissa, really make a difference?
Absolutely. Rehabilitation from day one is so important in terms of recovery. In the past, we've always thought of stroke as, stroke may have been thought of just an older person's disease and they've had a stroke and we'll...
stick them in the corner.
Absolutely. Whereas, a lot of the research has shown us that such great outcomes can be achieved through rehabilitation.
So, Deb, what are the proportions here in terms of people who die, rehabilitate, do well, all that?
Well, you alluded to the fact that there are a proportion of patients who die post-stroke, and that's about a third of patients. A third of patients have significant disability, and of those, some of them don't get home. And then you've got a third who actually improve to the point that their quality of life is so much better and they can almost get back to where they were before.
So does rehabilitation shift those proportions?
Yes and no. Obviously, it really depends on the type of stroke that people have sometimes and the patient's comorbidities lots of factors that actually influence the outcome, not just rehabilitation.
So what factors do influence outcome? What are the determinants of a good recovery?
The type of stroke is probably the key thing. The larger the stroke, the more deficit the patient has, and therefore the rate of recovery is often slower. So getting the patient to a rehabilitation service and providing that care is of the utmost. As I mentioned before, comorbidities. So if the person prior to their stroke wasn't managing so well because of functional decline, either because of heart disease or pulmonary disease or cognitive issues, that all impacts on their recovery and their ability to return home. And then obviously if the patient isn't able to have those supports that to get home, then all the amount of intervention in the world isn't going to provide them with a safe environment for home.
So let's look at the proportions of our viewers. Quite interestingly, for a rural health broadcast, 44% say that they're in metropolitan areas, 16% in remote, 12% in rural, and 26% in regional. So there's some major city interlopers, but you're very welcome indeed. What are the urban-rural differences in rehabilitation?
If you were looking at stroke rates, stroke morbidity and mortality, unfortunately rural areas do worse than urban areas in that respect. And overall, across Australia, there are less rehabilitation beds, if we're talking about inpatient beds, in rural Australia versus metropolitan. So access is a big issue.
Michelle, how important is one's social environment to recovery?
Oh, it's absolutely essential, and I think one of the things that that's happened in recent years is the partnership that's often worked out between the family of the stroke survivor themselves, and their inclusion in the therapy process right from the acute stage through the rehab and then back into the community. And another factor which is really essential is a really good supportive community, and I think that's one of the areas where rural areas can in fact have an advantage over metropolitan areas, because you'll often find a much more solid community support in rural areas.
We talked about the patient journey, Debbie. Maybe you should just remind us what the patient journey is, because it's a way of focusing on patient-centred care.
Well, as we talked about, and I think we've got Jack, who we're going to actually use it as an example, but really what we're trying to do here is focus on the patient as opposed to the service provision. So after Jack's stroke, he comes into an acute setting and then possibly into a subacute setting and then into a community setting. But the reality is he spends a very small amount of his stroke recovery within an institution, and we really want to focus on that continuity of care and continuum back into his community, which is the most important part of his stroke recovery.
And in terms of the of this patient journey, I just want to remind you that if you want to actually know about acute stroke care, you've got to watch that first programme, which will still be on the Rural Health Education Foundation's website. Tonight we're going to be talking about the latter half of that journey, which is in rehabilitation. What, Melissa, is the access to rehabilitation like? What are the issues there?
Look, I think it varies greatly across the country in terms of access. Certainly access to any organised stroke service in rural and regional areas is extremely limited. Right across the country, in terms of stroke units, we have in Australia about 20% have dedicated stroke units.
And just to remind us here, what we're talking about with the stroke unit is essentially a multidisciplinary team care focused on the person with stroke.
Yeah, an organised unit of care where they've got specialist staff with access to education and well coordinated service with a leader. Yep, so that the patient gets the approach from a dedicated team who are very experienced in stroke. So in terms of access...
But just to pin this down, because it flows through to rehabilitation, we're talking here about occupational therapy, physiotherapy, speech therapy... social work,
dietetics, medical, nursing. So that would be your more core sort of team, and then there might be others such as neuropsychologists, obviously access to your more specialist areas like neuropsychologists becomes more limited as you become more rural and remote.
In fact, the National Stroke Audit suggests that there's no neuropsychology available in small rural areas or remote areas. So
already trying to get the access is limited. So what do you find are the issues in terms of access? Because you're lucky, you've got a rehabilitation unit.
We have a rehabilitation unit. I'd agree that neuropsychology, we don't get any access because the nearest one is Coffs Harbour, so that is an issue for us. But what's been important is establishing a good local team, and we're fortunate our major stroke unit is at Port Macquarie, and so we've actually even have some of the allied health, but the occupational therapist comes from Port Macquarie across to our rehab unit, so we've got some continuity going there. We have regular meetings in the area so we do maintain continuity. But when we established the unit, one of the things that we were supported was to actually get adequate therapists, physiotherapists, occupational therapists, and in fact we were able to get speech services which we previously hadn't had at the hospital. So one of the things was a great capacity when they were looking for places for us to set up this unit was to be able to lobby and be able to get the good level of service.
We're talking about access to inpatient units, but the reality is in many areas they look at different models of care, like community rehabilitation or outreach. And I know Northern Territory runs on a community rehab centre and outreach, which unfortunately is still under-resourced across many parts of...
So, okay, we've got our nice multidisciplinary team together, but I haven't really got a picture of what happens to somebody. I mean, are we working, these poor patients 8 hours a day? The speech therapist comes in, hits them hard, then the occupational therapist and so on. The therapist, please give me a moment to myself. I mean, what actually happens though when we talk about this multidisciplinary rehabilitation? Well,
I think we need to be aware that rehabilitation is offered to patients in a specific way. So it depends on the type of stroke, it depends on where the patient is in their journey.
But you talk about rehabilitation starting almost in the ambulance.
It can indeed. And I think that's a really important point, because rehabilitation starts at day one, but we're focusing on different parts of the rehabilitation process depending on where the patient is in that process. And rehabilitation is goal directed. Okay, in the ambulance. For instance, if the patient has to be transported 5 hours to an acute stroke unit or the nearest hospital, then we have to make sure the bladder isn't distended. That's good patient management to make sure that we're not doing something that's detrimental. Assessing the swallow, making sure that the patient's actually had a stroke. Ambulance officers do very well at identifying what's happened to the patient in that respect.
And give me some idea of the modalities that you use in rehabilitation, the sorts of tricks of the trade.
You can look at any of the therapies and they're all using different evidence-based practice. The AVERT trial, if we're talking about early, is actually focusing on limited amounts of movement therapy that's directed towards making sure that the patient has some intervention early on, so that it might be sitting for 5 minutes 4 times a day, it might be transferring, it might be moving their arm. So if we're talking about motor interventions, that can be as simple as that in the early stages. And then if we talk, Melissa's specialty is speech.
So give me an idea of the sort of speech things that you do for people.
So depending how someone may present, in the earlier days we certainly might be looking very much at their swallowing function. So the ultimate aim is to make sure that we're preventing complications such as an aspiration pneumonia.
But can you teach somebody to swallow?
So absolutely, there's some evidence-based therapy that we can do. So certainly for some of the speech pathologists out there, using things such as what we call the shaker therapy is available. Different food and texture modifications may benefit, again, depending on the type.
And what about the different kinds of aphasia? Can you train people back to speak?
Certainly. Again, there is, and I would probably highlight to people to access the national guidelines which are available for stroke rehabilitation and recovery, which do provide different levels of evidence for all the individual disciplines. Certainly some have, some of the interventions have stronger evidence than others, and it's areas that we need to work on. But in particular, in terms of communication, some of the evidence may support specific cognitive-based type therapies, or I think Warwick and Michelle would back me up on the importance of training families and carers in communication strategies, and also other health professionals. That's very important, particularly in those early days in terms of communication.
And I think just for the people on the webcast, those guidelines are actually, I think, linked on your on your webpage there for the PDF file, and those of you who want to get them will also be able to get them off the Rural Health Education Foundation website.
Norman, we're talking about rehabilitation in the terms of facilitating recovery. And the interventions that we've just talked about are trying to enhance that. But there are other interventions that actually look at compensation strategies. So there are many parts of the rehabilitation.
Compensation strategies?
Yes, like if someone's unable to use, they have a flaccid or a non-functioning arm, then single-handed dressing strategies or even eating one-handed.
But there's also these things like tying down the bad arm and getting the other arm working because you get contralateral effects.
And those are the things that are actually targeting functional recovery through neuroplasticity. We know that the brain is actually working a lot earlier than what we initially anticipated. As Melissa alluded to, people said, don't do anything, but now we know the sooner we get on to producing that plasticity and all of those interventions like constraint therapy, mirror imaging.
Mirror imaging?
Yes, looking in a mirror and getting the patient to think about moving their unaffected limb, but think that it's their unaffected limb, so that you're actually stimulating the side of the stroke. So just thinking about...
So you're titulating the sick side of the brain.
That's right. Just thinking about that movement actually improves that plasticity.
And when you talk about assessment here, Warwick, are you talking about everybody in the team coming in and doing their own assessment, or which could be a knackering experience in its own right?
Well, I think the most important assessment is actually assessing the patient. Really looking at the person and finding out what their life has been and what's meaningful for them in their life. Because if we can direct the process of rehabilitation around what have been meaningful activities for them, so they can actually maintain some hope and a sense of that things in the future are going to be good. Because I think that they come in and it's such a frightening experience, but if we can get them, if we know what it is that's been important in their life, and we can start directing them to start thinking about the recovery and so having a meaningful life. And so that's, I think, an important initial assessment. And the other assessments of this coming according to obviously the priority. A person with a swallowing difficulty, that's the most, a really important early assessment. Then they're coming in for the physio and occupational therapy to also set up a range of activities that also the family members can support. They're also really concerned, and it's important for them to maintain their hope that this...
So they should be involved in the rehabilitation process as well. So Michelle, presumably from day one you're planning the discharge?
Yes, you are. Right from the word go, you're looking at what the goals are for that person in their life, and you're also including the family in that discussion. So getting them all together in a meeting so that they can see and they understand what's happening in rehab, so that they can participate in that as best they can, so they can continue that rehab when it goes home, but so that they're also setting the goals with the therapist, with the person who's had a stroke, so that everybody's on the same page as they move in through the rehab
But of course,
process.
recovery can go on for years.
Absolutely, and people have got functional recovery back for several years after. And certainly within our association, 20 and 30 years down the track, we've still got people who are working towards small goals, and certainly their goals aren't huge, but they're still working towards goals that they know they can achieve. And that's the important thing, is the patient determining what they want to achieve and moving towards that.
We've got a question in from one of our web viewers. I've read that giving people levodopa during stroke rehabilitation, these people do faster. Any comments? That's from Marissa Pillar in Northern Queensland.
There have been some limited studies with levodopa in head injury. I can't think of anything specific in stroke patients per se, but so the evidence is slim, I think, but it depends on the type of stroke and certainly what the goals are in terms of using levodopa therapy.
Let's go to our case study now, and it was previewed by Deb a moment ago. Jack's a 65-year-old farmer with a property 30 kilometres out of a small rural town. He's had poorly controlled high blood pressure, raised cholesterol, smokes up to 15 cigarettes a day. His wife Gill contacts you, Warwick, saying Jack's had a fall and is having difficulty speaking. It's almost 5 hours post-stroke when he arrives by ambulance at your unit, and he can't walk, he's leaning heavily to the right, and his speech is difficult to interpret. Your patient.
Right. Well, We're going to have a thorough look at Jack. We're going to want to assess, certainly to make sure there's no other things that we're unaware of. We want to make sure he hasn't had a myocardial infarction. We'd like to look at all the particular, assess the risk factors. We'd like to be in contact with our area of stroke, acute stroke unit, and discuss the fact that we have Jack there. And I guess the assessment of how much we do would depend on the distance that he has to travel to that acute stroke unit. For us, that's only a 20-minute journey by ambulance, and so that we look at, once we've made the decision and we know that he's medically stable for the transfer, then we're getting him to the stroke unit as soon as possible.
What are your transfer protocols? Because a lot of people watching will wonder that. You know, when you have somebody with a stroke, is it worth sending them? Is it not? Do you keep them? All that sort of stuff.
I think for certainly the distance that we are, with the local ambulance actually wouldn't bring an acute stroke to our hospital, would actually bypass us and take them to the base hospital, as it's only a short distance. We're looking at even at transient ischemic attacks as well, and a number of those we would transfer if we felt that they needed more urgent assessment.
And this is with a more modern approach which says that transient ischemic attacks really are more like strokes than just transient events.
And if you're aggressive with that, you can significantly change outcomes.
Particularly if you've got a 3-hour window for thrombolysis.
Yes.
So it's essentially anybody with an acute stroke gets transferred?
Yes. Yes.
Melissa, I mean, you've set up this network of stroke units in New South Wales.
Yeah, certainly we've been very lucky in New South Wales to get some funding to pilot various rural stroke models over the last couple of years. And the models that we've been piloting have all been based around the same key concept, whereby we have a hub, which is usually more in a regional centre, and that is your stroke service. And then each of those hubs have a spoke site, and that will be your smaller outlying sites and more likely more remote towns. Now, the point of those models is that basically those hubs, the stroke service supports those smaller sites. And really in New South Wales, we're just in the development phase, and certainly in Warwick's area, they're a bit more advanced and have some of those protocols established.
And are other states copying this thing?
Certainly they are. We've been lucky to probably lead the way a little bit, although some great work has been happening right across the country. And
with a similar model?
Yeah, with similar models and similar concepts.
And David, whilst we're not talking about acute stroke care, my memory from the last programme is that acute stroke units do make a big difference. If they've got thrombolysis, it's an added benefit, but you still get an awful lot of benefit from just going to multidisciplinary team care from the beginning.
You've said it, multidisciplinary team care that's organised into a discrete unit makes a difference both in acute stroke and in rehabilitation.
So we've got some more questions. What's the current research about outcomes for younger stroke patients, for example, under 55 years? Damien?
Younger patients actually tend to do better, but again, it really depends on the stroke. I mean, we've alluded to the fact that...
So if it's a thrombotic stroke?
Yes. I think
and if it's a hemorrhagic stroke? Or
different outcomes. It really depends on the area, and unfortunately, hemorrhagic stroke, we won't have enough time to tease out the differences here tonight, but it really depends on the area of the stroke. We were talking about younger strokes, and I think they often get a little bit more airplay because, of course, we often think about it as maybe that's going to be me. But we were talking about outcomes, and sometimes it depends on the patient's determination. I have a patient who's a dentist who had a left middle cerebral artery stroke, who was right-handed, who got back to dentistry. I think you were talking about another patient that you have. I think while we say it depends on the type of stroke, it's really often the supports that that patient has and the determination
to
succeed. Yeah.
The other this question obviously comes from Victoria. Given that the average length of stay for a stroke survivor in subacute is 33 days in Victoria, is it true to say that resources generally do not allow for optimum periods of time spent in the rehab setting? Debbie?
You're asking someone who's
This is a Dorothy Dixter, I suspect.
You're asking somebody who's just left the public hospital system, and I would agree. I think that it makes it incredibly difficult, though there's about to be a review in Victoria at least about service provision and resources. And I think I'm a part of the Australian Stroke Coalition, and they're lobbying to look at making things much more uniform across Australia.
Now we mustn't. Well, actually, we'll ask a question of the audience, and then we'll come back to this. Here's another poll question for those of you watching on the web. How far away is your nearest stroke unit in your location? Under 1 hour away, between 1 and 2 hours, or more than 2 hours? So how far away is your nearest stroke unit? If you go to your polling tab and answer that question, we'll give you the answers shortly. tell us about the FAST campaign again. It doesn't do any harm to remind us.
No, it doesn't do any harm. Look at the face, so smile, see if there's any facial weakness, lift up your arms, see if there's any arm weakness, try and speak, and if any of those things are not what they should be, then it's time to get to your nearest hospital.
Let's go to our next part of Jack's story. Jack's now in the emergency department in the acute stroke centre and has a CT scan. The CT scan reveals a left middle cerebral artery infarct. He's got a dense right-sided hemiplegia, which is affecting his mobility. He's got atrial fibrillation, difficulty swallowing, expressive dysphasia, and he's emotionally labile. Debbie?
This is a big stroke. As you can see from the CT, he's got a significant area affected, and his impairments, as you listed, are quite significant. So he's going to need quite a long period of rehabilitation, and optimally we would provide that within an inpatient unit, at least initially. We were talking again about what's the most appropriate place for this patient to be, and I think that sometimes we have to go on where the patient comes from and what supports are around there. So while I say inpatient rehabilitation for some time, it may not be that he's always in that setting. It may be more appropriate for him to be elsewhere in the longer term.
What would be his prognosis?
I think I have many patients with this sort of scenario who walk out of rehabilitation. And again, it really depends a lot on his family and his supports, his determination, and the making sure that there's no complications, or minimising the complications, and looking at his secondary risk factors, because unfortunately, he is at risk of dying just simply because he's had a stroke.
Melissa?
I think possibly the other things to consider in his prognosis, Jack lives 30 kilometres from a small rural town. That may mean that Jack is actually 150, 200 kilometres from his major rehab centre. And certainly, if he's got supportive family having to travel those distances, or that really impacts on rehabilitation outcomes, not being around the local community. That can really change levels of motivation within rehab, and I'm sure Michelle can comment on that.
So what's the
as well.
implication there? The two implications. One is he goes home too soon, and the other is that he actually needs to stay in rehab longer because he's not going to get it when he goes home.
That's right, and it's a catch-22 there.
Michelle?
And you'll often find that somebody in Jack's situation will want to go home, that they will be resistant sometimes to rehab because they're wanting to get back and feel that when they get home things may return to normal. And I guess the implications for the therapists is that they have to weigh up the benefits of him going home, as you said, too early, or putting extra effort into making sure that when he gets home it's going to be in a position where he's safe and his family are able to continue his rehab at home.
The beauty of many therapists is that they're very innovative and they think outside the square, and if they can use their resources to actually provide a meaningful pathway for Jack, then he's likely to get the most out of rehabilitation.
So basically here, going on our previous discussion, if he's getting state-of-the-art care, he's had a rehabilitation assessment on day one. He's got discharge planning from day one.
He has.
And everybody's had a look at him to see what their specialty is going to do for him. So what do you do in a resource-poor setting where you don't have all those people around? And I know you're lucky that you've got them, but
Yes.
I'm sure you know colleagues who don't.
Firstly, you've got to assess what you do have there, and then you have to assess what skills the family have. One of the things we've found very helpful is actually having the family involved in therapy sessions right from the beginning. So they know that when they come to visit Jack in hospital, then they can take on and encourage Jack with some exercises that are appropriate for him. They can be guided by the speech therapist to help him improve his speech. And the other aspect is they can also build that capacity, that thoughts within Jack that he's going to get home. And this is where the local GP is really important, because often he knows a lot about Jack. He knows what sort of personality he is, and he knows maybe the ways to actually encourage him and motivate Jack to help him with that recovery. So they're important things when he's getting back into that local community.
And how different would it be for Jack if he had receptive dysphasia?
Certainly receptive dysphasia would affect Jack's rehabilitation in that it impacts on the whole team in their ability to give Jack instructions in terms of his rehabilitation. So from a physiotherapy perspective, it's important, if they're considering gait retraining, that they would have to make sure that their commands are quite simple, that they use, yes and no questions, a lot of gesture, so Jack's able to actually follow what they're requesting to do in therapy. Likewise, right across the spectrum of therapies. So I guess it just proposes a few more challenges in Jack being able to actually comprehend particularly what the team's trying to achieve there.
What do you do about the emotional problems? If you're emotionally labile and you're going to...
I think the emotional ability, sometimes this is fear, and so you've got to address the issues of fear. But the other thing is also depending on what they see their future as. So one of the things we find that actually helps to settle them emotionally is to, in their room, for the family to bring in photographs of the home setting. Photographs of all the people who are meaningful in their life. Sometimes with farmers, we've actually had the dog brought in because, if the dog sits around with the farmer, that actually settles them down. Sometimes we've actually, when they're able in a wheelchair, to go out in a wheelchair taxi to the farm or something so they can smell the farm. I mean, these are sort of things for some people because they actually...
Just that connection, Michelle.
The connection back to what's their life, yes.
And the other thing is for the family to understand what's going on at this point too. So they need to know that the emotional ability is a side effect of the stroke, and give them techniques about what to do and how to handle it when the person may be tearful and not to be overcome by that themselves, and to help them through and maybe joke a bit, and some simple strategies that can assist them to make it more comfortable for him or her. So
here's the result of your location to your nearest stroke unit. I'm having a bit of trouble actually doing this because there's one category that I'm not sure. I suspect that over a third of you don't know where your stroke unit is. A third say it's an hour away. And about 1 in 5 of you say that it's more than 2 hours, and about 6 or 7% of you say that it's between 1 and 2 hours. So if Jack came, here's another poll question for you. If Jack came to your hospital, how soon would you be able to do a full rehabilitation assessment? Within 24 hours? Within 48 hours? Within 1 week? Or more than 1 week? So again, go to your poll tab and we'll follow you there. Now let's go back to Jack. Jack's now ready for transfer to a rehabilitation unit. It's 13 days after his stroke. Well, first of all, what are the criteria that you know he's ready for transfer? Debbie?
Warwick alluded to the point of medically stable. Obviously, if stroke units aren't co-located, and I must say that's the preferred option nowadays, so that people can get transferred to rehabilitation earlier, and there's integration between the service and communication and education. But say Jack needed to go to a standalone unit, then he would have to be medically stable, and he'd be ready to undergo therapy-based treatment for at least 2 or 3 hours a day. That's usually our criteria. The other thing is that he'd need to have some goals towards improving his outcomes. So we'd need to sit down with him and the therapist and his family and decide what areas of treatment he required to get back home to the farm and to his dog.
So it's 13 days after his stroke. He's transferred to the rehabilitation unit on a modified diet. He's got ongoing communications difficulty, is unable to move his right arm, but increasingly able to use his left arm to feed and dress himself. He's incontinent, requires 2-person transfers. He's still emotionally labile, anxious about the consequences, and particularly concerned about what will happen to his farm. And his wife is also distressed and worried about their future. What would be your approach at this point, Michelle?
Oh, I'd be spending quite a lot of time with both Jack and with his wife. I'd be looking at what community supports were available out in the community. I'd be particularly paying attention to the issues that were of concern to him and trying to set up some systems of continuing the work with the farm, maybe through extended family or maybe the next door neighbour. Those sort of things are often easily available in country areas, but I would be spending a lot of time with his wife and himself, making sure that they understood what was happening to them and what the next stage in the processes were, and keeping them on track in terms of the goals that they had established with both the therapists and the medical staff at that time. Looking at the fact that the aim really is to get him home in the best, with the best, abilities as possible. Thank you.
Question here, are there any complications from prescribing antidepressants for someone who's had a stroke?
I suppose that's for me. Well, newer antidepressants aren't as sedating, and that's probably the one problem that we've had with the older antidepressants, plus the interference with constipation and bladder involvement. So we would prescribe newer antidepressants like the SSRIs that were non-sedating. They can have a reduction in appetite, and there's not really a lot of other side effects. Some people report reduced libido. It's not usually a problem post-acute stroke. May be a problem.
Do they
down the
actually
track,
help,
though.
given that it's a reactive depression?
Yes, it does help. Obviously, you're not going to prescribe everyone antidepressants, and there needs to be an assessment of Jack's both cognitive and emotional and his functional goals. And it may be that you're prescribing an antidepressant to make him feel better so that he can participate in the rehab process in a much more meaningful way. The goals of medication have to be weighed up against both his comorbidities, but antidepressants per se are very good in that respect. They don't interfere a lot with other medications and do improve outcome.
As functional improvement continues, what support services are important once the patient returns to the community, Melissa?
I guess it depends on the community that they're returning to, because obviously a community in a regional centre is going to have access to a lot more support services, such as be it home care, access back to that rehabilitation facility, stroke recovery clubs, support groups, which Michelle can allude to. I think there's also things in terms of follow-up, specialist follow-up. So if we're perhaps talking to some of our more rural and remote audiences, we maybe need to think about the use of some innovative things such as telehealth or video health to actually link in specialist services back to the community settings, and also I alluded to the models in New South Wales using hub and spoke. A key component of that is stroke care coordinators, and that their role is to actually follow through the patient journey and follow up in the community.
It's also really important to think outside the square of just stroke. There are a lot of services out there that are available for people with chronic illnesses, which may be of benefit to somebody who's had a stroke. So I'm thinking of things like Vision Australia and services they can provide, and they're particularly important for rural Australians. Things like guide dogs have excellent services, and they actually have a stroke service which are available in rural Australia. But organisations like Technical Aids for the Disabled, which can come into a person's home and actually build services or actual aids which are specific for that person's disability, and organisations like Independent Living Centre, which are really very good at having a range of functional aids which can assist people to live independently much better. But the other things to look at is what other groups are available. If there's not a stroke support group, is there a carers group in the area? Is there a senior citizens group? Is there just a young persons group? And often the things that we don't always look at are things like church groups or just any sort of social groups that might be operating in that community, which somebody who's had a stroke can quite easily access as well.
Warren?
Yes, I agree with all those things are really important. It's really getting back to a person of what's meaningful in their life and encouraging them with that. And that's going to be different for each person. So there's not going to be one prescription that fits everyone. And so that's a really important role for the local doctor who knows the person to actually really be actively involved in that, and also planning the follow-up. Some of these people, we have some people who come back in again for further rehab, and and we get referrals from the GP who says, well, this person, it's now maybe 12 months after their stroke, but they've actually come up with a particular problem, and so that they think that if we can spend another 2 weeks and we can focus on trying to improve that particular area.
Let's get the poll result. If Jack came to your hospital, how soon would you be able to do a full rehabilitation assessment? Good news. Well, again, our metropolitan people are pretty lucky. They can do it within 24 hours. That's about 1 in 4. Well over half of you can do it within 48 hours. 16% in a week, and a small minority of 4% more than 1 week, probably overlapping with the people in remote areas, but not a bad result. Nice to get it immediately, but But you can certainly see the difference between city and country very graphically there. Tell me about FIM scores here, Warwick.
Okay. FIM is a functional independence measure, and it's a way of assessing a patient, and you assess them in a whole range of different areas. You're assessing them maybe in their eating, in terms of their grooming, bathing, dressing, bladder control, their walking, and the scale is such that a person who has an assessment in one unit, people in another unit will know exactly what that means. It's a measure from 1 to 7, and it determines the level of assistance that they require. So it also sets a baseline when a person starts off. We can assess where they're at, and we can look at which particular areas we need to, in order to get them home, which ones we have to reach a certain level.
Michelle, the national guidelines talk about patient feedback. What's the story here?
I guess it's really important that all the way through the rehab process that the patient is involved in their discussion on their care, so that...
so it's been done with you, not on you. Not
that's right,
again,
and that you are a partner in that process. And I guess it's really important that, you know, over time our members have given us some feedback on the sorts of things they like or dislike about rehabilitation services, and it really comes down to a couple of things, but basically it is that personal care, that acknowledgement of the individual as being an individual, and wanting the encouragement to continue recovery and not taking away the hope. And a lot of that is just the personal connection that can happen between the stroke survivor, their family, and also the therapists that are working with them. And it's that really positive push, and we often do push very much in rehab, that people work hard towards recovery. But if that's done in a really positive way, in a really respectful way, then feedback about rehab is often very positive.
I'm going to ask another poll question. It may well be a redundant question given our previous answers, but I'll ask it anyway. How far away is your nearest rehab unit in your location? Under an hour? Between 1 and 2 hours? More than 2 hours away? I suspect we know what the answer is, but we'll just get your result by going to that poll tab. Sorry, what were you going to say there?
I was going to actually add to Michelle's comment about therapy. Now, you know, we're really focused on goal-directed therapy so that everybody's involved in that process, and most rehab units I know have meetings very early on with the family and the patient and with their team to actually identify where we're headed. That makes a huge difference, I think, to outcomes, because people are focused and know what. And as Warwick mentioned, people come back to rehab saying, look, I want to be able to perhaps nail some toys together because that was my hobby previously. Can you show me how I can do this? And they might have some therapy that's associated purely around that task.
Tell me about eating difficulties and when you put in the nasogastric tube, when you put in a peg, when you put in...
Look, again, that really varies on how the person presents. Different people have different philosophies on how early or how delayed peg feeding should be initiated. It does vary.
But it's been controversial, peg feeding.
Look, it is, and that's where I say different places will initiate peg feeding early versus later. And it depends. Obviously, if someone's presenting with what appears to be a long-term swallowing difficulty, then peg feeding is often an option. I think the important thing to highlight, though, is it's not final, and it needs to not be considered a final option. That, you know, it might be that someone's on a combination of peg feeding and some oral intake, or that their swallowing function is reviewed.
Does oral intake actually train you back? In other words, by not having oral intake, are you actually disabling somebody even more?
I guess as one of the, you know, something I used to often say to people, one of the best things for swallowing is swallowing, to improve swallowing.
It's not going down your left knee bronchus.
It depends, that's exactly right. You've got to weigh up the risks of if that swallowing difficulty is going to result in aspiration pneumonia, which is going to result in worse outcomes. So, you know, there's a lot of factors to consider in terms of the
And any special tricks with bladder management?
Not to over-distend the bladder really, and I think I alluded to that fact when we were talking about ambulance transfer. Also to keep the bowel working, because if you've got a full bowel then you're not able to get that stimulus into the bladder, and you also need to have good assessment of both of those functions so that you know where the patient is. Obviously if you don't know that they don't have sensation in the bladder, then you're not going to get it working well.
I think it's important to highlight too about bowel and bladder management that, it's actually a whole team approach. That, you know, it is the roles of everyone. So, you know, physiotherapists in terms of mobility, in terms of getting the person to the toilet. Speech pathologists, so goal might actually be to assist with the person being able to communicate that they need to go to the toilet. So it does need to be a whole team approach, bowel and bladder management.
So the results of the rehab unit, is there a rehab unit within an hour, 2 hours, more than 2 hours? More than half are very near one indeed, 25% in an hour and 12.5% more than 2 hours, and then about nearly 10% within an hour. So it's not too bad, but again, biased towards our metropolitan audience. Again, very welcome. And so Jack's now ready for discharge. How do you know? You've reached your goals, is that what it is?
Yes, yes. In many ways, that's exactly what it is. We've been talking with Jack and his family. We've talked to the team on a regular basis. That's the nice thing about rehab. We work in the team environment. We are able to identify from each of those members about where we're at. The other thing is that I think that Jack's journey is really, as we talked about before, he's ready when we know that he can be offered supports on his continuing journey outside of the hospital, and that's really important to get right, because as Warwick said and Michelle have said, you know, patients really need to be as good as what they can be when they're home, and if they're not, then we've got to have some way of actually providing them the support that they need.
Could you discuss another question on depression as a side effect of stroke? Without neuropsychologists readily available, how do other carers and professionals deal best with depression after stroke? Warwick?
I think this is where, you know, certainly the general practitioners would be aware of, you know, dealing with depression quite often. It's actually, you know, you've got to assess what's actually going on for that person. You want to know what they were like before. Did they have a tendency towards depression before, which may have not been diagnosed? So it's, you know, and it may involve an assessment by a range of people. I think the social work is very important in our team in terms of coming in and talking to the people and maybe uncovering a number of issues. And if we needed to, we could.
Does cognitive behavioural therapy work in people who've had a stroke?
I think it depends on really the disability with the stroke, how much are going to be able to utilise that cognitive behaviour therapy. You know, there's certainly a percentage that certainly are quite capable of being able to work through that sort of approach.
I was just thinking that, you know, you can try medication is obviously a vital asset in dealing with depression after stroke, but I guess there are a number of other things. Reconnecting with your community through a stroke support group or through other support groups is also essential, but looking at other things too, like getting out into the community, out into the sunshine, making sure that exercise is part of somebody's daily processes. All the holistic things that you would normally do with somebody who was depressed is also the sorts of things you'd do with somebody who was stroke affected.
And you use medication as a facilitator of all of those other things. If the mood can be lifted, then often
it lifts the lever.
Yes, exactly. And my process is always to make the patient and the family and the general practitioner aware that this isn't an ongoing treatment. You reassess at a point in time and say, do we need this medication?
Would biofeedback help in bladder retraining? Yes.
Many physiotherapists are trained in biofeedback and work in continence clinics throughout the country, and for stroke it's a similar mechanism. It's identifying those triggers that the patient's able to utilise, and sometimes it's a matter of teaching the patient to identify what's actually happening within their body so that they can use that biofeedback.
Is there a difference between the management of stroke in children and adults?
I don't particularly work in paediatric stroke. I have had, you know, 15 and 16-year-olds. Often the neuroplasticity is much stronger in young children.
But the same principles apply.
Same principles apply, but they often do much better.
Within our remote area hospital, we've combined our acute unit and rehabilitation together with a small dedicated multidisciplinary team. We're proud of us.
So they should be.
Congratulations.
Yes.
And what are the special needs for the first Australians, for Aboriginal and Torres Strait Islanders, and how can we better support them?
You've got to understand how important the family is to Aboriginal people. The family, which may be an incredibly large, extended group of people.
And the community on the whole.
The whole community. I mean, they've got so many aunts and uncles, and it's important that they all can be available to support, and I think that's critical. It's a very frightening experience for them, and so the more community support, and this is where hospitals think have to be a bit more flexible, because you might have in a rehab unit, normally you've got sort of strict visiting hours, but you might have to sort of be able to negotiate something with that family, because that person may have extra.
And presumably working with community liaison and Aboriginal health workers as well to really mobilise those. Michelle, do you have much experience of that?
Just that there are specific services set up in terms of Aboriginal health, and you would certainly be incorporating those, and in particular, when somebody's going home, Aboriginal home care services are available throughout various states of Australia. So you'd be making sure that all the services that were specifically available for Aboriginals were basically mobilised by the time the person goes home.
So just going back to the options here for Jack, we really covered them all, I think, already in the programme. So supported care, community rehabilitation, mobilising whatever, as Michelle said, whatever resources that you have. And you've been talking about middle level, multi-skilled people who know a bit of physio, a bit of OT, and
yes, and I think that for rural and remote communities, and if we were talking about Aboriginal communities as opposed to Jack per se, we'd be wanting outreach to be the most important part of that patient's journey. For Jack, he may live so far away from a regional centre that his inpatient or community centre that we have multi-skilled workers who actually are able to carry out, under the supervision of more experienced people, a program for Jack within that community that's goal targeted towards what Jack really wants to do.
I think we need to highlight the importance of education programs as well. So, the people sitting in smaller facilities, be it the sole nurse or the GPs, are such innovative and resourceful people that the education from the stroke services is really essential to promote.
And provide networks.
Yep. Let's get through some questions though. We've got lots of them here. Advice on seating, importance of wheelchairs, pressure relief cushions, arm supports. Is there a research on the best way to manage positioning?
I'm not an OT, but I advocate one of the key things about acute stroke management is actually good support and positioning, because you have to start with good truncal support to be able to walk in the longer term. So if you've got good seating, you've got supported cushions to reduce pressure, you've got arm rests that actually provide support for the affected limb, those things are all helpful. They cost lots of money in most instances.
What's the evidence for splinting the flaccid arm in somebody with a stroke? That's this whole contralateral thing, isn't it?
Yes. Well, there's good evidence to suggest that contralateral or constraint therapy is what I think we're talking about.
So this is constraining the affected arm?
Yes, constraining the affected arm. That's what I think that they were asking. To improve neuroplasticity and be able to forcefully train someone to actually use that arm. It's very intensive stuff, and it often causes great frustration to the patients because they're affected. So you don't actually constrain them for the whole of the day, otherwise they'd be trying to kill you, I think.
Right, yeah. Recently, as a stroke liaison at Warrnambool, your territory, Debbie, I've encountered an increasing number of younger stroke survivors in their 50s who need more than the local stroke support group has to offer. What can we offer these people post-discharge? Do you want to pick up that one, Warwick? And then I'll come to Michelle.
Yes. I guess, again, with an individual, you need to look at what are the issues for that particular person and say what particular areas do they seem to be having difficulty with, and it might need to liaise then with the experts in that area to see how you might be able to improve that. I'm not quite sure without a specific issue to
Michelle?
discuss.
I guess I'm making the assumption they're talking about things like returning to work and those sort of issues for somebody in their returning to driving in their 50s. And there's certainly with returning to driving, there's a number of programs set up through occupational therapists and the local hospitals that I'd be suggesting they access. But in terms of returning to work, there's an enormous number of support processes set up through the Department of Employment and Relations in terms of assisting people with disabilities back into the workforce, and that can just be assisting them to get a job, it can be retraining them, or it can be looking at what positions that they had before and then maybe looking at changing that to something that would be more suitable for them now. So I'm assuming that they're talking about a more active involvement in the community than just attending a stroke support group.
Although we have a rehabilitation unit in Darwin, there are only 8 public beds for the entire territory, and they're not purely for stroke. This impairs effective multidisciplinary team management, as there's no stroke unit either, rather frustrating.
I have to say Darwin's got a fantastic unit, and they work out...
So they have got a stroke unit?
Well, they've got a rehab unit, works out of a tin shed, and they've got great, very great therapists who actually think outside the square, and without them, I think the Northern Territory would be really sunk.
How can we support and empower people with stroke and their family and the community? Often they feel like they're dumped by their health professional. What's the role of self-management? Michelle?
I think self-management is essential, because I think that the health system plays a limited part. The GP is certainly a lot longer part than rehab in the acute setting. Self-management is absolutely essential. So I guess going back to the themes that we've been putting through all the way through the program is that it's important that the person takes control of their own health, takes responsibility, and through self-management looks at their own goals, continuing on from rehab, and so that they basically are taught strategies that they can do for themselves in physiotherapy, in occupational therapy and in speech therapy, and they take that as their personal responsibility and goal. But I think they do that in relation with their GP.
It's important to realise that this is not a short-term process.
No,
this recovery period is going to go for years. And
well, in fact, we've got a comment here. When I trained, this is one of the comments from a speech pathologist. When I trained in the dark ages, it was thought that post-stroke recovery was only going to continue for 6 to 12 months. What's the current evidence for the time period for post-stroke recovery?
Well, in actual fact, the recovery lasts much longer. What most of the evidence is focusing on now is how to promote early recovery and to enhance that over that short period of time in rehabilitation, so that people can build on those enhancements as they move out into the community.
West Australian webcaster asks from the West Australian Stroke Rehabilitation Online Network, would it be a good idea for stroke survivors to be taught computer and internet skills to avoid isolation? Michelle?
We've just run a program in our stroke support clubs for internet training, where we have reconnected our members through the internet training. The other thing that is available out there is a lot of reduced cost computers for people with a disability, and anybody who wants more information on that can certainly contact me, and I'm more than happy to put them in touch with the areas that they can get those sort of low cost computers, because the internet is the growing thing. And what we've found is that they may not want to talk in chat rooms, but it's amazing how the internet has opened up a whole new world for stroke survivors, not only in continuing their recovery and learning more about their stroke, but just a whole world out there that they may not be able to access anymore because of their disability.
An occupational therapist asks, at what point post-stroke can people return to driving?
Well, they have to have a medical assessment first before they can even access a driving assessment, and that's purely because there are some levels of disability where it isn't appropriate for patients to return to driving. And the thing that comes to mind most of all is vision. If there's a vision problem, field defect or double vision, then that precludes you. And then dependent on comorbidities and the type of disability, then they'll go on to have an occupational therapy assessment, usually driving assessment I mean, to make sure that they're able, so that fatigue is looked at, concentration, attention, being able to manipulate the steering wheel, the all those sorts of things on site first before they even hit the road.
This comes from a nurse who asks, the National Stroke Foundation is about to launch a pilot project involving stroke-specific self-management and rolling this program out to 3 metropolitan health services. Any comments from anybody?
The National Stroke Foundation's been fantastic. They've the audit has actually highlighted that patients really wanted self-management programs, and to their credit, the National Stroke Foundation have really put in a lot of effort to actually provide that resource, and I look forward to being able to show my patients that.
We've encouraged some patients to use computers. This comes from a physiotherapist in Melbourne, in Victoria. We've encouraged some patients to use computers as part of their rehabilitation to open up their channels of communications. That's reaffirming the importance of that. And And another one from in the nursing profession, within the context of scarce resources, how do you engage with a patient and his or her family when it's considered the person has plateaued and they're not considered capable of returning home?
Can I just say that question is probably relates to something that I think we have to highlight with Warwick, is that GPs can often be the advocate for patients to access services. If you've got a GP that keeps hammering on the door and says, look, this patient really needs to go, or they've been at home, or they've been even in a nursing home setting, and they want these are the goals that I think that they can achieve, the GP is often very well placed in perhaps encouraging those rehabilitation units or community supports that aren't perhaps going to engage those type of patients.
We've certainly had people who've gone through a rehab process, and it may be quite extensive, and then they've had enough of the hospitalisation, and we've got them into the home setting with a view to bringing them back, and so that's the most effective way. They go home, they understand then and fully realise the areas they need assistance with, and are keen to come back.
So it's almost in a sense, Michelle, planning for failure.
Yes, I think it's important that
or allowing for the possibility of failure.
Yeah, but just going back specifically to that question, I think one of the things you can do too is, as Warwick says, you talk to the family about the fact that, you know, let's go home and try out how we've gone and whether or not we've been successful, and what are the things we need to fine tune, and then bring them back to do that. But when you do send somebody home, it's really important that you are, you know, they're prepared, so they've got a list of people that they can reconnect with if things don't go as they think that they may. So things like carers, respite services, making sure they've got the number of their local GP, making sure that they've got a connection back to the hospital if they want to clarify some facts, and making sure that they're linked into organisations like the Stroke Association and Carers New South Wales to get some support.
So final poll question for you out there. Is there a stroke care network in your area that you have access to? Yes? No? Don't know? What's a stroke care network?
Something that we've set up within New South Wales through our pilot for the rural stroke services was establishing a network of clinicians interested in stroke. So we recognise that in rural and regional areas that most clinicians are generalists, but they may have a specific interest in the field of stroke. So we actually have more than 300 clinicians on a list, and it's a facility for sharing information, resource sharing, giving evidence-based
happening in other
practice.
states as well?
Melissa shares with me.
Yeah, so we also link into a more metropolitan-based list, which does incorporate people from the other states. So if people are interested in linking into those lists, that would be great. You know,
and how do they do that?
They can contact me through the website, or also through the rural list can be accessed through the Institute of Rural Clinical Services and Teaching website.
So you don't have to be in New South Wales to access it?
No, you can access that, and it's on the resource page.
And Victoria have just have got a support network of stroke coordinators now, so they're working throughout the Victoria, so they're also a pivotal point for accessing education and information, and we've been sharing resources through the ROSE program and other programs across Australia, and I think that's a key point.
It's reinventing the wheel. We're all aiming to achieve the same thing.
So even though it started in New South Wales, a lot of people seem to think that there is a stroke care network near them, and given that we've got a very national audience today, we've had questions from Western Australia, from almost every jurisdiction, so there seem to be more networks out there than we
I'm sure
realise.
There's more than we know. We just
one place to look though is the National Stroke Foundation and the ASUN, which is the Australian Stroke Unit Network. They're two websites that people might have want to access to actually look at what networks are around.
Been a great program. So the messages I've got is you start planning for discharge right at the beginning. Presumably you go into people's homes right at the beginning to see what changes need to be made. Active rehabilitation from get-go in a wide range of fields, and really focusing on goals and measuring your outcomes in terms of goals. And if you get to your goals, then you know whether somebody can go home or not, or into other forms of rehabilitation, and you're using the resources that you've got. And thank you very much for taking part to the fantastic questions. What take-home messages have we got from the panel?
I think the most important thing is for people to maintain hope. and actually work it out what it is that the most powerful healing force is that which exists within the person. In this case, it was Jack. And if Jack's the one who's going to determine the outcome, that drive that he has, and wanting to get back to something which is meaningful, a life which is meaningful.
Michelle?
I just think the fact that you're not alone out there in treating people who've had stroke. There are experts that you can call on. There's a great deal of information that is easy to understand, not only for the people involved in the provision of service, but also for the stroke survivor and their family, and making sure that you and the therapists and the stroke survivor and their family are on the same page in moving forward with their rehab.
Melissa?
I think probably the importance of organised care where that can be achieved, and also just utilising the huge number of people that are interested in stroke through those networks so that we can all push towards implementing best care practice.
Debbie?
I'd go along with what everybody said, but I think organisation of care and utilising these sorts of broadcasts are also important. Education and delivering best practices is the way to go.
Thank you all very much. I hope you've enjoyed this programme, The Journey Back, Rehabilitation After Stroke. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. If you were one of the many viewers who had questions that we didn't get to, don't worry, we'll endeavour to respond to all of your comments and queries. Our thanks to the Department of Health and Ageing for making the programme possible, but thanks to you for taking the time to attend and contribute wherever you are, however you did it. I'm Norman Swan. Bye for now.